Hello everyone, welcome to part 1 of the Walden Health Assessment Midterm. This will be in 2 parts, with this first part covering weeks 1, 2, and 3. As a reminder, there are exam rules. The midterm exam is 100 questions. You have 2.5 hours to complete this. You may not use any outside resources or receive help from anyone or any resource around you. You need to study resources from weeks 1 through 6 in order to prepare for this exam. This exam is only open during week 6, so unless there is some emergent situation that happens, you must take it during this time, and failure to do so will result in a 0. This also needs to be done in one sitting. This means that you cannot start the exam and then stop the exam to resume it later. You have to take it all at once. It's also important that you read all of the instructions in the course before starting the exam so that you have a good understanding of what to expect prior to starting. In addition to the content that we cover in this presentation, there's a few additional topics that are really knowledge-based, meaning it's a simple number to memorize or definition to memorize. So as we get to these, I will provide some study guidance for this, such as this slide on labs. You want to go through and be able to answer each of the questions or bullet points listed here for the labs, even though we are not going to cover that during this session. It's also important to note that this session is meant to be a supplement to your studying, and it is not meant to be all-inclusive of everything that's on the exam. So you don't want to just do these presentations and then be done. You want to pay good attention to your required resources each week as well. Similar to the lab slide we just covered, this imaging slide should help guide your studying in the topic of diagnostic imaging. You want to know the types of imaging, the levels of radiation that are concerning, that harm may be caused, the body parts that have a high level of incidental finding on imaging, and what the problem with incidental findings may be, as well as what the problem with relying on diagnostic testing such as imaging can be. As the reason we cover the health assessment techniques is because we really want you to also be able to lean on those and not just imaging. We're going to start by covering week 1, which includes the health history and documentation covered in chapters 2 and 5 of your text. When completing any sort of health assessment, whether it's the history or the physical exam, it's first important to have a therapeutic relationship with a patient. A therapeutic relationship is important because the goal is to really facilitate health, well-being, recovery, and prevention within a patient. And because of this, it's really important that there is rapport and trust that are built pretty quickly within this relationship. So ways in which we can build rapport are to introduce ourselves and provide a handshake, ask if the person has a preferred name, pronouns, how they like to be addressed. We want to make sure that the environment is comfortable and that we are ensuring comfort not just physically but also emotionally, letting the patient know that it is a safe and shared space. Developing trust by being genuine and open, and really leaning into patient-centered questions, such as asking about their beliefs. What is their belief about their symptoms? What is their belief about their treatment? What's important to them? Who is important to them? How are they coping? And what concerns do they have? In building rapport in a relationship, a trick is learning the 4 C's: courtesy, comfort, connection, and confirmation. Courtesy includes such things as knocking, making the introduction, and again asking how they like to be addressed, focusing on them, not taking notes, making sure that you don't have a hand reaching for the doorknob, so don't leave too soon. We know that time is really important when you are managing a busy patient panel, but don't let the patient know that. Make them feel like you are present. And also respecting the need for modesty. Comfort, again, there's physical comfort, making sure that they have a physically comfortable place to sit or lie down, depending on the exam. Making sure that they feel emotionally comfortable, again, by being open, non-judgmental. Providing privacy and providing an environment that is conducive to comfort as well. Not too cold, not too warm, not too bright, not too dark. All of those things can make a big difference in how a patient feels in the environment. Connection is using language that is appropriate for the patient. Now, this may mean using an interpreter if English is not their first language and they are not able to fully communicate in English, or it can also just mean using language that the patient is easily able to understand. So really looking into their health literacy and avoiding jargon. It also is important to build connection through nonverbal communication. So making eye contact when appropriate, but also recognizing there's some cultural differences there. Using facial expressions, leaning into conversation. Don't have closed off nonverbal, such as arms crossed, and making sure that they know that you're being attentive. You can also build connection through including them in the plan of care and including them in the history. Again, those, well, what do you think? Questions. What do you think is going on? Or what do you think may be causing those symptoms? And exploring more about them. So if they tell you for an occupation, for example, oh, I'm a teacher. Oh, what do you teach? So getting to know them a little bit more to build that connection. And then finally, confirmation, confirming what has taken place so that you and the patient both leave any encounter with the same idea of what just transpired. So you can summarize or ask the patient to summarize. You can make sure you also follow up on any additional items. And make sure you follow it up with any unanswered questions. So part of confirmation is not just always knowing how to answer exactly everything in that moment, but following up when a patient has a question that maybe you don't know how to answer, saying, you know what, I'm going to get back to you on that. That helps to build trust for two reasons. One, they know that when you don't know an answer, you're not just going to make something up, you're going to look into it. But following back up with that answer lets them know that you keep your word. So when we are trying to elicit quality information during a health history, it's important that we do a couple of things and do not do a few others. So for example, we want to ask open-ended questions. Tell me about this. How do you feel about this? That is a not closed question, right? A direct question would be yes or no or something very brief. And open-ended questions really help to elicit the whole picture. We do not want to do a leading question. For example, you do use condoms, right? Or you only have sex with one person, right? Or do you know that sex can lead to pregnancy? Or you do know would be a leading question. We do want to ask direct questions when we want specific information. When did this first start? Do you smoke cigarettes? We do not want to ask judgmental questions. Now, why questions are a little bit tricky because sometimes we do want to know why because we're exploring and we're helping to build connection, but why can often sound judgmental. So if somebody tells you something and you say, why do you think that? That makes it sound like it may be wrong to think that. However, using the open-ended strategy of, can you tell me more about that? Can you tell me more on your thoughts? How did you come to those thoughts? That is more open than why do you think that? Why do you believe that happened? We do want to explore in neutral ways. Can you tell me more about? And we don't want to insert our opinion. Alcohol is really bad for you. You don't drink, right? That would be inserting our opinion. So you want to make sure that your questions do not unintentionally lead a patient down a direction that is not in keeping with what is actually happening in their experience. In addition to how we word our questions, there's other techniques to help facilitate the information gathering. One technique is reflection. This is after you and the patient have had an exchange, you paraphrase or reflect back to them what you believe you heard from them. This gives them a chance to confirm or correct any information that maybe you did not fully understand. You can also repeat with using a question at the end to elicit more information. If somebody says to you, I've made up my mind, I'm going to stop smoking, instead of saying like, hey, that's great, or are you sure you've tried that before, you can actually explore more information by saying, oh, you want to quit smoking? And then that inflection in your voice often prompts them to continue telling you what they're thinking and what's going on. You can also clarify. If somebody says something to you that does not quite seem in keeping with what you understand, or you're not sure what they mean, ask them about it. Ask what they mean, ask what their viewpoint is. It's really important to clarify when there's any sort of question, because it can help to make sure you understand, but also can help the patient to really dig deeper into those topics. Summarizing at the end of a section of a health history is really important. So for example, if I've just gone through their entire HPI, I can summarize it back for them. Or if I've done their past medical history, allergies, medications, surgical history, I can say to them, okay, I just want to be sure I have this right. You are allergic to penicillins and you get a rash. The only medication you take is loratadine for seasonal allergies. You really have no past medical history, and your only surgery was your C-section for the birth of your child. And that helps them again to confirm or correct any information. Offering points of empathy is also really important. You do need to be sure that you do this genuinely, but this can help. It helps with the connection. It helps build rapport and trust. So if somebody says to you, unfortunately, I just lost my father last week. I'm so sorry to hear that. That must be really challenging for you. You can also follow up with, how are you feeling about that? How are you doing with that? But empathizing is important. It's also important to confront, and I don't mean this in like an aggressive, confrontational way. What I do mean is if somebody says something that you're not quite sure is consistent with what they've told you before, or if you have a long-standing relationship with the person and you know it's not in keeping with what they mean, it's okay to kind of call that out. An example would be if somebody says to you, you know what, I just don't even care about that. It would be okay to say like, well, I'm hearing you say that you don't care about it, but your tone and your body actions are telling me that maybe you do care. Maybe you're a little upset. Can we talk about that? And that helps to engage with something when they may be trying to emotionally shut it down. It's also important to be able to interpret what somebody is saying. You do not want to make your own interpretation. So this is not saying like, oh, I'm just going to interpret what they mean. Asking them, this is very similar to clarifying. So, okay, my interpretation of what you just said is this correct? You never want to make your own assumptions. You never want to provide your own interpretation without clarifying with the patient. It's important to avoid jargon so that patients understand what it is you're trying to ask. You can also explore topics. So if somebody says to you, you know, my parents say that I'm not adopted, but I'm sure I'm adopted. I think I was given away to my parents from a couple that lived across the world. I don't know, something kind of out there. It's okay to say, why do you feel this way? Let's explore this. What is leading you to these thoughts to have a better understanding of what may be happening? And finally, it's also really important to encourage the patient to ask questions. If they're not sure why you may be asking something or what it is you're hoping to know, or if they're not quite clear on what you mean, it's really important that they are able to respond by asking their own questions. When you are in a situation where you're either discussing uncomfortable topics or you yourself are in an uncomfortable situation, there's some strategies that can help you with this. The first are to lean into your communication strategies. If somebody is discussing an uncomfortable topic and you sense that they don't want to address it, use those techniques we just talked about to try and get them to open up a little bit more. How do you feel about this? Can you tell me more about? Making sure that you are non-judgmental, you are not making them feel like you're asking a leading question, just being very open. It's also okay to explore denials. So if you're talking about something like sex, which a lot of people find uncomfortable, and you ask if they're sexually active and they're like, nope, not sexually active, but they ask it or answer it in such a way that makes you feel like there may be more there, you can explore a little bit further. Have you ever been sexually active? Can you tell me more about that? Are you having any sort of sexual relationships with people? Just to really help to explore. Again, it's really important that you are open in these uncomfortable situations. Sometimes patients want providers to share personal information, and it can be a fine line. So if somebody says to you, do you have any children? It's okay to answer them briefly, is whatever you're comfortable with, of course. You don't have to, but it's okay to share little bits of information that help to build connection. If somebody were to say, what are the ages of your kids and what school do they go to? And it no longer felt like it was just part of general conversation, you do not need to answer that, nor should you answer that. So there's always going to be this fine line that you walk with having a human experience, building connection, and also making sure that you are protecting what is, again, a therapeutic relationship, not a social one. And finally, if you have a patient that continues to put you in uncomfortable situations, or is not able to remain in a therapeutic space, it's also okay to ask for that patient to be reassigned to someone else, keeping in mind that the therapeutic relationship, again, that goal is really focused on their health, their wellness, their recovery. And if a patient is really focused on you, then that's not going to be the best really for their own health outcome. So it's okay to ask for reassignment at that time. So what are some barriers to communication? As we just discussed, asking about you, making sure you share just enough, but then redirecting, and if they can't redirect, asking for them to reassign. Anxiety. So if somebody is super anxious, it can be really hard for them to stay on track with all the questions you're asking. So you want to avoid overwhelm. An example of this would be in a review of systems with someone. If somebody is really anxious and you're going through a cardiac review of systems, we know that with review of systems, we often cluster things. Are you having any chest pain, palpitations, or feeling like your heart is racing? That can be a normal string of questions. But if someone's really anxious, it may be better to say to them, are you having any palpitations? It's also important to avoid overwhelm by considering what do you need to know right now. If someone is very anxious and they just need to get through whatever is happening, asking them about their sleeping habits, asking them about their current living situation, may be something you can circle back to once they have calmed down. It's also important that you pace your questions so you're not firing off a bunch of questions that can make them feel even more anxious, and that you're keeping a calm demeanor and that the environment is calm as well. Silence can be a barrier to communication in a couple of ways. Sometimes patients will use this as a strategy when they do not wish to answer a question. It's okay to rephrase or reframe a question when this happens, but sometimes that silence can be therapeutic. So if silence is happening because a patient is thinking or a patient needs to process, you also don't want to rush to fill silence, as that can be a barrier as well. If somebody is experiencing signs and symptoms of depression, sometimes this can feel like a barrier to communication because providers are concerned that if they bring up and really probe into possible thoughts of suicide, that may actually be the incorrect thing to do. So I put this here because I do want to reassure you that you do want to assess for thoughts of suicide. It will not push someone into thinking about suicide if they were not previously having suicidal ideations. And finally, strong emotions such as crying or anger can also be barriers to communication. During this time, you want to take a pause from your information gathering and allow the patient a moment to feel those emotions, process what may have brought those emotions about, and then be able to continue the conversation once they've had a little space. Additional barriers to communication may be, again, if a patient is focused on intimacy or inappropriate attraction with the provider, this would need to be reassigned to a different provider. If somebody is very angry, then you would want to explore their reasons for anger. You want to avoid being defensive or taking the blame. You want to use de-escalation techniques. And if someone is very angry, you want to focus on safety above anything else. If you sense that somebody is avoiding the full story, this can also be a barrier to communication, where it seems like they aren't quite giving you what may have happened, or at least not all of it. It's important in these situations to try to explore, but you don't want to push too hard. So again, you'll get into the groove of navigating between these two, where you do want to explore what that full story can be without them feeling like you're overwhelming them. And finally, financial considerations can be a barrier to communication. If a patient is concerned about their financial situation and you have not kind of gotten to that through your health assessment, they may be reluctant to disclose to you that they're not sure if this treatment plan is going to be for them because they don't know if they can afford it. So there can be financial considerations that are really important to consider when communicating with a patient. Now that we have explored different ways of communicating, let's get into the health assessment itself. Please keep in mind that it's really important to know the difference between subjective information and objective information. This often gets confused for people. The biggest area that I see this getting mixed up is in the review of systems, where people are supposed to be telling you if they are having or not having specific symptoms. Like we just talked about the cardiac example, are they having chest pain? Are they having palpitations? That is subjective. So anything the patient is telling you, HPI, past medical history, review of systems, all subjective. Objective is going to be data that you collect. Vital signs. Using that cardiac example, you're going to talk about how you've inspected their chest wall and don't see any abnormalities. You have palpated and you do not feel any abnormal vibrations against your hand. You can feel their pulses. You've auscultated. You've heard S1, S2. All of that is objective data. So as you go through and are practicing documenting, it's really important to always keep in mind what is subjective, what is objective. So what are the components of the health history? First, we have the chief complaint. Sometimes this is also the reason for visit. So the chief complaint would be if someone was coming in for a problem visit, and you either want this to be very brief or in the patient's own words. Very brief would be headache. In the patient's own words, I have the worst headache of my life. Reason for visit, on the other hand, this would be when there is no complaint and they are coming in for preventive care. I'm here for my annual exam. History of present illness, this describes their current health status. This is where the acronym OLTCART, you want to be really familiar with that. And also know that OLTCART, while it talks about onset, location, duration, what is the characteristic, what are alleviating factors and aggravating factors, does it radiate anywhere, what is the timing, all of those pieces. You also want to ask about how it's impacting their job or their life and what types of social supports they have to support them during this. HPI for a preventative visit, it's not going to have all those details, but you'd still want to ask how their current health is. For medications, you always want to ask the name of the medication, the route in which they're taking it, the dose, the frequency, and also the reason for taking it. Allergies, you want to document drug allergies, environmental allergies, latex allergies, food allergies, and always document the reaction with it. Immunizations and screenings, you want to do the ones that they would have been due. So for example, if someone is 25 years old, as a female, you would not need to document on a mammogram. But for anything that they should have already had, you want to make sure you have documented the date that they last had it. Past medical history should include any major illnesses and current diseases that they are experiencing. For example, if somebody had Lyme disease last year, even though they are not considered active with Lyme now, that would be important to consider there. And if they're actively being treated for high cholesterol, you would also include this in your PMH. Surgical history, which should also include any hospitalizations and traumas. Family history, you want to ask as many generations as you can, but realistically speaking, 3 is considered like gold standard. So if you can get parents, grandparents, and siblings, that would be 3 generations, or parents, siblings, and children, also 3 generations. But really getting a comprehensive family history to look for those patterns. Social history, this is where you're going to cover things such as sleep, stress, nutrition, occupation, exercise, substance use. Substance use sometimes is considered part of more of a psychiatric assessment, but that can go in here as well. And with substance use, you want to ask about preferred substances, how often they use them and get intoxicated, if they've ever had withdrawal, or if they have ever tried to quit. There's different screening tools that are out there for that. In the social history, you can also ask a sexual history and spiritual history as well. And finally, the review of systems, which, as we've stated, is going to go through each of the body systems and ask questions about symptoms they may be experiencing in that system. And the patient is either going to deny those symptoms or they are going to report that they are having them. When appropriate, please remember there are screening tools available that can help assess mood disorders, drug and alcohol use, intimate partner violence. These are the tools that can help really explore these topics in a way that gives you a good jumping off point and provides a little bit of quantifiable data on scales. It's important to use tools that are reliable and valid so that you know that they are accurately screening for what it is you are intending to screen. When documenting, again, it's really important to know the difference between subjective versus objective. You also want to be concise. Years ago, we used to say things like, AB is a lovely 36-year-old woman who presents after referral from her dear friend Betty, who lives down the road, to be seen today in my office. The notes were long, they were very flowy, but information can get missed that way. So instead, we want to be concise. AB is a 36-year-old female presenting for annual exam. We also want to make sure that we are factual, and so this is going to avoid any sort of our thought process in here. Stating that a patient looks disheveled, that is appropriate, that is factual. If you look at the chart and you see the patient has 5 children and looks disheveled, what you don't want to do is say, the patient appears disheveled today, but she does have 5 children, so she was probably having a rough morning. It may not be that case at all. So we want to make sure we are sticking to the facts and not putting in any of our own assessments and judgments for 2 reasons. 1, they don't have a place in the chart, but 2, it may prevent us to finding out what is actually happening and why this individual may present disheveled. We want to make sure that we avoid abbreviations, and if we have to use them, that we use approved ones. A chart should include the demographic information. So this is going to be their name, preferred pronouns, their age, ethnicity and race, insurance information. All of the demographics are going to be captured. The good news is with EMR, it's really static in the chart unless you go in to change it, so you do not need to collect this each time. You are then going to document in SOAP note form, so subjective information, all of the components we just went over. Objective information. Objective information is going to be, again, the data that you collect, organized by system. Then problem list. This is different than the problem statement that we are creating with our iHuman patients. A problem list is a list of active diagnoses that are kept in the chart, and it's not just diagnoses, but also factors that impact the patient's health. So if somebody is coming in and they are coming in for a birth control consult, but they also have high blood pressure and they are a smoker, all of those things are going to be on your problem list because they are all going to impact your decision of what you prescribe. Then is going to be your assessment. That's going to be your differentials and active diagnoses for the visit today. And then your plan. Plan should always include any diagnostic testing you need to order, any treatments, including medications that are prescribed or over the counter, as well as supplemental or naturopathic treatment options. You want to include education for the patient, any referral information, and follow-up. Now we are going to move into the week 2 content. This includes cultural competence from chapter 1 of your text and clinical practice guideline information. This comes from the Danes, Bauman, and Scheibel resource listed under required readings in week 2, and it is a PDF on chapter 2. So what are culture and cultural competence? So culture is really beliefs, values, attitudes, ways in which we communicate, and norms of a group. It's how humans relate to each other. It can be shared lived experiences. And individuals really may belong to more than one cultural group. So we can't say this person has this culture. This person may be a complex human who has many different cultural groups that they identify with. Cultural competence includes self-awareness and reflection of your own culture and values and biases, curiosity about other cultures, openness to other cultures, and an understanding that there's no right or wrong culture. Everyone's culture helps to define who they are and how they interact with the world, and understanding that that is important to them without it being either good or bad. Cultural sensitivity, again, is having that awareness of cultural factors, being able to learn about other cultures, and developing a respect and understanding for other cultures. Cultural intelligence, on the other hand, is really application of cultural competence and cultural sensitivity into human interactions. So in order to become culturally intelligent, you do have to have that self-awareness. Again, you have to really look at yourself, understand your own culture, your own experiences, your own biases, and this is a constant process. So it's not just I've done that, check mark, moving on, I can now be culturally intelligent, but it should be something that happens quite frequently. Cultural intelligence also includes needing to learn about other cultures and really recognizing the similarities and the differences between cultures. Oftentimes we focus on the differences, and that means that they are apart from us when we focus on differences. But when we begin to focus on the similarities and the differences, we start to see commonalities. It helps to humanize each other and helps to really have that understanding of the experience that a different culture can bring. Cultural intelligence also involves interacting with different groups, and again, it's a continual process of going through all of these steps in order to really become someone who can apply cultural knowledge into those human interactions quite comfortably. So what does culture impact? Culture can impact our health practices, our spirituality, our language, and our communication that may be nonverbal or communication patterns as well. It can impact our family interactions, how our community supports us. It can impact our dietary practices. So really, culture can impact everything about who we are and how we interact with the world. So what is it not? Culture and race are not synonymous. Race is actually a social construct and not a scientific grouping or definition. Instead, race is really a vague way of grouping individuals that have genetic similarities. It does not define beliefs, values, or a way of life, and it's really important to understand the impact of racism while also acknowledging that race in and of itself is not culture. So you cannot say that individuals of a certain race behave, believe, interact, or engage in a certain way. Ethnicity, on the other hand, does tend to group individuals who come from shared ancestry, and in this case, ethnicity is more likely to have shared culture than race does. Any physical characteristics are also not synonymous with culture, and we can't make assumptions on culture based on physical characteristics, and we can't make assumptions of physical characteristic based on culture. And culture is also not a stereotype. So while we define cultures in certain ways and we understand different things about different cultures, every individual within a culture may not be 100% what we've learned. So it's always important to have that individualized understanding to avoid stereotyping. So how do we achieve cultural competence? We talked about this a little bit with cultural intelligence, but it's worth reiterating. We want to develop an awareness of the importance of culture, understand the meaning of culture, respect how culture influences our lives and our choices, assess patients' cultural beliefs, particularly regarding their care, becoming aware of disparities and discriminations, and really developing cultural humility. Sometimes this will come up when a patient wants to participate in a different type of medicine or ritual that they believe will impact their health positively. And as healthcare providers, sometimes we can be quick to say no if it does not fit with what we have learned in our allopathic medicine or Western medicine training. However, when we have achieved cultural intelligence or cultural competence, we can recognize the benefit of many types of healing modalities and the importance of honoring someone's culture. In this case, allowing them to engage in any routine or ritual or treatment modalities that are not unsafe and do not violate any healthcare rules or laws, anything that would be impossible, right? As long as it is not something that's going to cause harm or break any system issues, we do encourage you to encourage your patients to participate in whatever healing modality they believe will help their health. So there's different dimensions in which we can experience cultural competence. This is cultural encounters, cultural desire, cultural awareness, cultural knowledge, and cultural skill. And as we grow in each of these dimensions, again, then we can apply this to our everyday human interactions to become culturally intelligent. So one of the things that's important to keep in mind with culture is that we know that individuals from certain groups have large disparities in healthcare. So while sometimes this is about race or ethnicity, it can also be sexual preference, it can be gender identity, it can be disparities within certain socioeconomic groups. So there's many ways in which disparities can exist. So how do we reduce these disparities? First, it's important to reflect on conscious and unconscious bias. We know that there is a difference in the human experience for individuals who are in a thin body versus individuals who are in a larger body. If we make unconscious choices based on a bias against those in larger bodies, it can impact our healthcare. So it's really important that we are aware of our own biases so we can keep them outside of our patient encounters. It's also important to humanize everybody. And remember, we're not talking about a disease process. We're not talking about a trait or a characteristic. Our patient encounters truly are humans. So we need to make sure to always humanize them and keep that in the forefront. We want to be inclusive of any support system the patient has, including friends, family members, partners, whoever their loved ones may be. If possible, you want to learn common language phrases if there is a language discrepancy between you and your patient population. It's really important to use medical interpretation if the patient is not fluent in English. You also want to make sure that you are avoiding jargon and really communicating on a level that is consistent with late grade school age, because most patients, even if they are very well educated, may not have high health literacy. It's also important to advocate for groups who we know are marginalized or more vulnerable to disparities. And finally, if somebody is really struggling financially, it's important to negotiate a plan. So if there is a treatment that you think is going to work great for a patient, but it's incredibly expensive and they can't afford it, it's not likely to be successful. So negotiating a plan is a better option. For example, when treating obese patients, it is incredibly difficult right now to get insurance to approve GLP-1 receptor agonists such as Wegovy or GLP-1 RAs and GIP RAs such as Zepbound. And so if you were to say to a patient, hey, we've got these great meds that are being really successful, I'm going to prescribe it for you, and that's it, then they may never be able to access that medication. Whereas if you are able to engage with the patient and really negotiate a plan, look at how much something is going to cost, look at other options that may be more attainable, really look at the resources that somebody has, and it's not always just financial resources. Maybe it's something that has to do with distance and transportation, but you always want to make sure you're negotiating a plan so that the individual patient factors allow them to be successful in a treatment plan and do not increase a potential disparity. That brings us to learning about major social determinants of health. So when we're talking about disparities, there are many things that can drive these disparities. So disparities are often defined as the difference in health outcomes for two groups. So we know that those who are economically stable versus those who have significant financial issues are going to experience health disparities. The same is true for level of education, access to health care, what their neighborhood is like, and also what their social and community support is like. This is why taking a detailed health history that includes all of these factors is important in helping you ultimately decide the best treatment plan for your patient. And finally, it can be helpful to really use this respect model, which you can find in your text, where you are basically building a partnership with a patient that helps you to be the most successful in determining the treatment plan for them. So respect stands for rapport, empathy, support, partnership, explanations, cultural competence, and trust. Now we're going to move on to the second part of week 2, talking about evidence-based guidelines. And so guidelines often use different types of evidence, and they're brought about largely by professional organizations who take a look at all of the evidence and come up with options based on what is available. So when we look at levels of evidence, this on the slide here is particular to the USPSTF, U.S. Preventative Services Task Force, recommendations for screening guidelines, for example. So we want to look at the quality of the information that's out there and make sure what we are recommending is beneficial and not harmful. So in terms of screening guidelines, the USPSTF does this by looking and grading the levels of evidence, with A being high certainty, high benefit, B being that there's moderate or substantial benefit, C meaning that you're moderately certain the benefit is quite small, D meaning, well, now you're pretty certain that there's either no benefit or that there are risks that outweigh the benefits, and I would be insufficient evidence. And so then what we can do is take this evidence and apply the grade to determine what preventative screenings we are going to recommend for someone. When we evaluate the evidence, this can come from professional organizations, as we just looked at the USPSTF, or it can be something that we have to do because maybe there isn't a treatment guideline that's out there or a screening guideline that's out there. So how do we evaluate the evidence? Well, first we want to look at the design and make sure it's appropriate for what is being tested. We want to look at the quality. We want to look at the depth and the breadth of the literature all around. Is there just one study? Are there multiple studies? Do those studies agree? Is there consistency of results? Are there other additional factors that could impact the results of the study? And so the first 5 here are really about evaluating literature and research. However, it's also important to note that anecdotal evidence often comes before are research. Research takes a large amount of time in order to plan the study, complete the study, analyze the results, and then publish them. However, with anecdotal evidence, we can take advantage of what we are experiencing with patients right now in order to guide treatment options. An example of this is there was a lot of data on Wellbutrin or bupropion for the treatment of depression. This is how it was FDA approved. This is where all the major studies were. And when we started giving it to patients, we noticed that they were able to quit smoking. And so now we have this anecdotal evidence of, hey, this drug may be very effective at smoking cessation. And now the anecdotal evidence is telling us maybe we should use it in this way, and eventually the literature caught up. Finally, there is empirical evidence or empiric evidence, and this is evidence that's acquired both through observation and experimentation. So this can include observing certain things that maybe we have not been able to experiment on. When we talk about empirical evidence, it's really a broad way of categorizing different research, including quantitative, qualitative, and mixed method, as well as just observational data. This is different than you'll hear the term empiric treatment. Empiric treatment is actually taking some evidence that we have and applying it to different situations. For example, with certain infections like bacterial sinusitis, we do not do cultures typically and send them off before treating. Instead, we know that the most common pathogen for bacterial sinusitis is going to be susceptible to augmentin. And so it is empiric treatment to prescribe an antibiotic for a treatment based on what we know is the most common pathogen. This is different than empirical evidence. Finally, we're going to look at week 3, which covers chapter 3 in your text. It's important to note that when completing a health exam, we are in a patient's space, we are sharing space with them, and so we always need to consider infection control. This means that prior to us making contact with the patient, we should be sure to engage in hand hygiene, that for any part of the health assessment, we are using PPE, and that we are always following safe infection control practices. When setting up for the exam, it's important that we provide privacy. This includes privacy during changing. Even if you are about to do a reproductive exam or a GYN exam, it's still important to give them privacy when changing. There should be curtains that block the door so that if a door accidentally opens during an exam, there is a curtain preventing the individual who accidentally opened a door from seeing the patient. There should be appropriate draping. So if you are having someone get fully undressed, there should be a gown that covers them fully that can be easily opened in sections so that you are exposing only what needs to be exposed at the time of the exam. If you are using a sheet to drape, it should be a sheet that is a full sheet and not one that just covers a small portion. It's also important that our draping and gowns come in different sizes so that you don't have one patient who's having a hard time keeping it on because it's so big and another that can barely cover themselves. And again, during an exam, you want to make sure that you are only exposing what is necessary. It's important to know that as we go through the different health assessment systems, we are going to see different positions. You want to be familiar with these positions, such as seated, supine, prone, dorsal recumbent, lateral recumbent, and lithotomy, and when you will use each of them. And then finally, we're not going to get into a lot of detail about the equipment and the techniques in this part because we're going to apply the techniques and the equipment as we talk about each system coming up. So inspection is our visual observation. Palpation is the palmar surface of our hands and finger pads to assess position, texture, size, fluctuance, crepitus, masses, or any sort of structure, using the ulnar surface of our hand to sense vibration, or using the dorsal surface of our hand to sense temperature. Percussion is listening to the tone that is created by striking one surface against the next, and it's important to note what each of these are as well as what examples of them are. They include tympanic, hyperresonance, resonance, dullness, and flatness. And finally, auscultation, which is listening to sounds heard that the body makes in order to assess the quality of the sound, the type of sound, and what it may be associated with. This includes our review of weeks 1 through 3. Please be sure to reach out to your faculty if you have any questions.